Coming up in this episode. Next is all about marking. It helps so much, especially if you're doing it in the lateral position. So I've got my trusty surgical pen that I carry around with me in my pocket all the time. And I first palpate out the iliac crest, and that's the L4 level. And that's important because, as we know, the spinal cord ends in the adult at the L12 level. Hello, and welcome to the next installment of Wristfeld Neurology Education, a not-for-profit, free open access project with a philosophical touch, exploring all areas of clinical neurology, meant for medical students through to neurologists and all health professionals caring for patients with neurological conditions. I'm your host, Tom Wristfeld, a neurologist, epileptologist, a neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. I'm excited to announce that this episode, titled How to Perform a Lumbar Puncture and What Tests to Order, is the first episode in a new series on neurological procedures. And before we begin, a legal disclaimer. The content of this episode is for educational purposes only. So let's dive into it. Firstly, what are the indications for a lumbar puncture? Well, it's actually more than you might think, and it's a super helpful procedure. I remember 2 or 3 years ago, I was having a conversation with a geriatrician and general physician, and we were talking about the indications for lumbar punctures. And he was a lovely doctor and very good with his patients and a very good geriatrician, although he didn't quite understand the utility and the range of indications that a lumbar puncture can be helpful for. His understanding was that lumbar punctures really are just for excluding meningitis, infective meningitis. But as you'll soon learn, the indications for a lumbar puncture far exceed this. So, firstly, yes, suspected infective meningitis, along with aseptic meningitis, which can either be infective or non-infective, is one key indication for a lumbar puncture. Also suspected encephalitis, which of course can be infective or non-infective, so it could be autoimmune or paraneoplastic, for instance. Suspected subarachnoid hemorrhage if the non-contrast CT brain wasn't performed within 6 hours, or even if it was and you would still like to do a lumbar puncture to definitively exclude a subarachnoid hemorrhage to look for xanthochromia. Also, suspected idiopathic intracranial hypertension, IIH, formerly known as BIH or benign intracranial hypertension. And in this instance, it's both diagnostic by measuring the opening pressure, but it's also therapeutic by relieving some of that pressure. And a lumbar puncture can be therapeutic in some other instances as well by releasing the intracranial pressure, such as in the context of cryptococcal meningitis. Lumbar puncture is also helpful in suspected cases of central nervous system malignancy, whether that be solid organ, primary or secondary malignancies, or hematological malignancies like lymphomas. If you have a patient with suspected central nervous system vasculitis, which could be a primary vasculitis, so PANCS, primary angiitis of the central nervous system, or primary CNS vasculitis, or it could be a secondary vasculitis, so a more systemic vasculitis like a giant cell arteritis or autoimmune connective tissue disease with a vasculitic component which is involving the cerebral vasculature, or a number of other neuroinflammatory conditions, including but not limited to sarcoidosis. Of course, a lumbar puncture is very important often in the context of suspected demyelination, for instance, to support a diagnosis of multiple sclerosis, MS, if oligoclonal bands restricted to the CSF are necessary to meet McDonald's criteria. So, for instance, if you don't have enough based on the clinical presentation and the radiology to meet McDonald's criteria and support a diagnosis of MS, then you may require oligoclonal bands in order to make the diagnosis of MS. And it's sometimes also useful in the context of optic neuritis and transverse myelitis and other optic neuropathies and myelopathies. And it's often also helpful in NMO spectrum disorder, MOGAD, and ADEM, acute disseminated encephalomyelitis. It's also very important and helpful in cases of acute peripheral neuropathies, such as suspected inflammatory acute peripheral neuropathies like AIDP and its variants, or in other words, suspected Guillain-Barré syndrome, GBS, or in more subacute or chronic forms of inflammatory peripheral polyneuropathies, in particular CIDP, chronic inflammatory demyelinating polyneuropathy, and that's principally looking for a elevated CSF albumin with normal cell counts in the CSF. So that's called albuminocytologic dissociation. A lumbar puncture is also important in the context of a rapidly progressive dementia or an early onset or an atypical clinical presentation of a dementia. And that's, for instance, looking for CJD, Creutzfeldt-Jakob disease, or potentially treatable and reversible forms of a rapidly progressive or atypical dementia, such as a limbic encephalitis, which was already mentioned a few moments ago, or also to support the diagnosis of a more typical form of a dementia in a young onset patient, for instance, by looking for CSF biomarkers, for instance, for Alzheimer's disease. And it's also important in the diagnostic evaluation of NPH, normal pressure hydrocephalus, by way of what's known as a TAP test or a high volume lumbar puncture. And that's actually diagnostic and therapeutic. So you remove a high volume of CSF, up to 35 to 40 milliliters, and then you do a gait and a memory assessment before and after to look for any improvement. And that's essential in the diagnostic workup for NPH, a potentially treatable, reversible cause of dementia and extrapyramidal features. Lumbar puncture can also selectively be useful in some cases, particularly atypical cases of brachial or lumbosacral plexopathies, especially if you're considering an infiltrative or a malignant cause for the brachial or lumbosacral plexopathy. And in addition to that, lumbar puncture is sometimes also needed for intrathecal therapies used in neurology. For example, nusinersen in the treatment of some forms of spinal muscular atrophy. I haven't personally had to inject nusinersen, but two of my colleagues have, and I understand that it costs hundreds of thousands of dollars per vial. So I think they were quite stressed about dropping the vial, but thankfully they didn't. And of course, it's also used for intrathecal contrast injections if someone requires contrast myelography. Although in that instance, usually it's the radiologist performing the contrast myelography, which does the contrast intrathecal injection at the time. I've tried to make this a semi-exhaustive list of indications for a lumbar puncture. I'm sure I've forgotten a few, but this hopefully indicates that there really is a broad range of indications for lumbar puncture, and it really is a very useful procedure. So it's one that it's really important to be comfortable with and efficient and safe performing. So what are the contraindications to a lumbar puncture? Well, the two big ones that everyone thinks of, firstly, is if there's a suspected significantly raised intracerebral or intracranial pressure, I should say, ICP, in the context of a space occupying lesion. And this is because of the risk of herniation or coning, in other words, particularly cerebellar tonsillar herniation through the foramen magnum causing brainstem compression. That would be a disaster. So, how do you identify whether there may be concern or suspicions that there may be raised intracranial pressure in the context of a space occupying lesion? Well, really, that's based on your history and your examination. So, if there are significant risk factors identified or symptoms suggestive of an intracerebral malignancy or hemorrhage or examination findings which may be suggestive of that, like papilloedema or focal neurologic deficits, then that's when you need to really think about this. And in which cases, some form of neuroimaging, usually a CT brain, is indicated. And if it shows any abnormality, then it typically requires a discussion with the neurosurgical team, and they'll assess the risk and they'll be able to comment on whether it's deemed safe to proceed or not. In my experience, usually the neurosurgical team says, yes, it's fine. There's sufficient space around the basal cisterns and around the foramen magnum and the base of skull, and they've generally said it's okay to proceed with the lumbar puncture. Of course, that's going to be on a case-by-case basis, and that may not always be the case, especially if the patient is already coning or on the verge of coning. And in that instance, if you really need a CSF sample, then the CSF needs to be collected from above the site of the pressure, not below. So they just need a direct neurosurgical method to obtain some CSF if that's really necessary. Although the neurosurgical team have sometimes recommended taking some form of extra caution. So, For instance, if there's sufficient space and it's okay to do a lumbar puncture, but there's a bit of doubt, then they might recommend using a particularly fine bore needle, an atraumatic technique, and removing a relatively small quantity of CSF. It's also possible that some of the earlier literature that indicated this as being a significant risk may have, to some extent, overstated the risk of iatrogenic coning from lumbar puncture procedures. The other main contraindication to a lumbar puncture is the patient being on active therapeutic anticoagulation or having an underlying uncorrected or unstable bleeding diathesis. So, firstly, in terms of antiplatelets, not anticoagulants, antiplatelets, single antiplatelet therapy, especially with aspirin, should be completely okay to do a lumbar puncture on. Clopidogrel monotherapy and clopidogrel combination therapy as dual antiplatelet therapy is a bit more controversial. Personally, I think it's completely okay, and I've done hundreds and hundreds of lumbar punctures. Many of those patients were on clopidogrel monotherapy or dual therapy, and I've never had any problem with bleeding or spinal hematomas or problems like this. Although I do acknowledge that some authors and some bodies do caution to some extent against lumbar punctures being performed on patients on clopidogrel in mono or combination therapy, although it's always going to be a balance of benefits versus risks. And there isn't a strong body of literature or evidence indicating that it is a significantly increased risk. Prophylactic anticoagulation, so enoxaparin at 20 or 40 milligrams daily, or unfractionated heparin at 5,000 units twice or 3 times a day, is fine to do a lumbar puncture on. Where you run into problems is if the patient is on therapeutic dose anticoagulation. So that means warfarin with a therapeutic INR, or really any INR of 1.4, and a patient who's on therapeutic doses of apixaban, rivaroxaban, dabigatran. It's not okay to do a lumbar puncture in these patients. And there are clearly published guidelines on how long you need to wait after the last dose of each of these agents and any additional blood tests that you need to do prior to performing a lumbar puncture safely. And it's also based on the patient's renal function. In particular, there's a publication in Practical Neurology in 2018 published by the Association of British Neurologists body, and I'd recommend that. That's my usual go-to, although it does seem a bit aggressive to me in terms of the time that they wait, in terms of some of the DOACs in particular. And in my experience, there's been a few times that I've LP'd patients on apixaban or dabigatran or rivaroxaban after waiting what I consider to be the relatively short period of time that they recommend, and the patient has bled quite a bit during the procedure. There hasn't been any significant bleeding and spinal hematomas, but I do like to wait a little bit longer than they recommend in terms of the DOACs if possible. But again, it's always going to be that balance of benefits and risks and how quickly you need the lumbar puncture. For some anticoagulants, there may also be options in terms of reversing the anticoagulant in select cases on a case-by-case basis. Now, by extension, if there is a significant active uncorrected bleeding diathesis, whether that be inherited or an acquired bleeding diathesis, so maybe the patient has hemophilia, maybe they have an acquired vitamin K deficiency, maybe they have an acquired coagulation factor inhibitor, then that's significant. And so if you clinically suspect a bleeding diathesis in a patient, then it's essential that you do the appropriate blood work first. So checking their platelet counts, making sure that they're over 50, checking their coagulation profile, so their prothrombin time, their INR, their APTT, perhaps more advanced coagulation cascade and coagulation profile testing in a patient who has a known underlying inherited bleeding disorder, just to make sure that it's stable and safe prior to proceeding with the lumbar puncture. And as I've mentioned a few times, ultimately it's a balance of benefits versus risks in terms of performing a lumbar puncture. And no one's doing a lumbar puncture for fun when it's not indicated. So if a lumbar puncture is needed, then usually it's needed. Of course, there will be some that are needed more urgently than others. And it's really about balancing the benefits versus risks, how long you can wait, what you can do to mitigate those risks. Some other contraindications, which are a bit more obvious, are things like any local infection or trauma at the intended puncture site. And one other thing is be wary of the patient with local anesthetic anaphylaxis as a previously recognized problem. So always check allergies before you do the lumbar puncture. I have been involved in a case where a patient did have a history of anaphylaxis to lignocaine and to local anesthetics. So the lumbar puncture had to be performed under general anesthetic instead without the use of any local anesthetic agent. So, how do you consent a patient for a lumbar puncture? The first thing that I do is I like to just explain the procedure to the patient step by step, not in medical terminology, but from their perspective. And I do find that that helps to allay patient fears, it addresses their questions, and of course, it's required in order to obtain informed consent from a patient. Patients often really dread and fear and are very hesitant in regards to a lumbar puncture. So I find that taking the time to talk to them about the procedure, talk to them about the risks, and explain how those risks are mitigated can really, really help to calm the patient, make them more confident and happier to proceed with the procedure. So, the main risks that I state when I'm consenting a patient are firstly infection, but I say that the risk of infection is very low and mitigated by the meticulous sterile technique that we use. So, sterile gowns, sterile gloves, a sterile drape, and a sterile alcohol and chlorhexidine cleaning solution, so that the risk of infection is very low. Secondly, the risk of bleeding. But I say again, this is mitigated by the lack of you being on any strong therapeutic anticoagulants at the moment and the lack of you having an underlying active or uncorrected bleeding diathesis. Thirdly, the risk of transiently brushing up against a nerve in the vicinity where the procedure is being performed, and that this may cause a split second jolt like feeling shooting down a leg. But then I state that it would be very uncommon for any actual damage to be caused or any neurologic injury to actually be caused at a structural level. And lastly, and probably most importantly, because it's the most common side effect that we do sometimes run into, is the risk of a post lumbar puncture headache. But I say that this is mitigated by us using thinner needles these days than we used to, so using a fine bore needle. And if I'm using an atraumatic needle, then I'll say it's also mitigated by us using an atraumatic needle. And I also say that most patients who have a lumbar puncture don't have a post LP headache, and those who do have a headache, usually they're benign and self limiting, but occasionally they are a more significant headache in the context of a sustained CSF leak. And if that's the case, the numbers I quote is approximately 90% of these headaches respond to conservative management. So that's lying flat, staying well hydrated, and staying well caffeinated. So at least 3 strong coffees a day. Or if you're using caffeine tablets, at least 100 milligrams 3 times a day. Or if that doesn't work, so only approximately 10% of patients that that's insufficient for, then you may require a repeat similar procedure to plug up the gap. And of course, that's an epidural blood patch procedure. So they're the 4 main risks that I routinely state to every patient when I'm consenting them for a lumbar puncture. Now, if I can tell that the patient is obviously very nervous and anxious, I often offer just a low dose of an anxiolytic. So, for example, diazepam, 2.5 to 5 milligrams orally, perhaps 45 minutes prior to the procedure, depending on the patient's body habitus and whatever other medications they may be on, just to take the edge off a little bit, provided there's no contraindications in this patient in particular. And I have found that this can really, really help enormously if your patient is calm and still during the procedure and they're not having a panic attack and hyperventilating and moving around. It just makes the world of difference for achieving a successful lumbar puncture. So, what equipment do you need to perform a lumbar puncture? Firstly, you need a trolley or some other surface to set up on. Then you need your LP kit, and that should contain a sterile field, a drape, gauze or cotton balls, forceps, the little plastic forceps for using the gauze, a manometer for measuring the opening pressure, the CSF tubes, and a dish. And depending on which hospital you're working in or which country you're working in, there may be different LP kits that have different combinations or types of equipment in them. So it's always good to check that you know what's in the kit before you start using it. One thing I will say is that different kits in Australia at least have different drapes, and some of the drapes are great and some of them are terrible. So the really good drapes are nice and big with a nice big fenestration, ideally with a sticky bit on the side of the drape so that it sticks nicely to the skin. And the really good ones are transparent drapes so that you can actually see the patient and the skin underneath the drape so that you can help navigate in the three planes of space when you're doing the procedure, although most of them are not transparent like that. On the other side of the coin, some drapes in lumbar puncture kits are terrible. They're these tiny little flimsy drapes which barely even create a sterile field with a small fenestration and no adhesive, and you put them on the side of the patient and they just fall off and they're a joke, really. So if you've got a lumbar puncture kit that doesn't have a good drape in it, I would recommend getting a separate drape to use that and make sure that it's a fenestrated drape, because sometimes you get a drape and then it's not fenestrated, and that's no help to anybody. Now, in terms of the lumbar puncture needles to use, some lumbar puncture kits do have a lumbar puncture needle in them, but usually it's not the right needle. So you should almost always use a 22 gauge needle in an adult. So that's a relatively thin or fine bore needle. And in Australia, they have a black tip on them in the hospitals that I've worked in the states that I've worked in. You do not want to use the larger needle, which is the 20 gauge needle. And in Australia, they've got a yellow tip on the back of them. The reason that I say this is you might think that it's only a 2 gauge difference between the two. Surely it's not that significant. But wait until you actually look at them and feel them. There really is a world of difference. And literature has shown that there is a very, very significant difference in terms of the risk of a post lumbar puncture headache between using a 22 gauge and a 20 gauge spinal needle. So please use the 22 gauge needle. The one exception to this might be if you're doing a very high volume lumbar puncture tap, mainly in the context of a tap test in the diagnostic evaluation of normal pressure hydrocephalus, where you might need 35 to 40 milliliters. In that instance, it's probably not unreasonable to use a 20 gauge needle, although even then, usually a 22 gauge needle will still be sufficient. Now, in addition to the gauge of the needle, the type of needle is also important. So ideally, you would use an atraumatic needle. And literature has shown that these also have a lower risk of a post-LP headache than the sharp cutting tip needles. However, I will say that the atraumatic needles are much more difficult to use. So they have a introducer, which is sharp and cutting to get through the skin and the immediate subcutaneous structures. And then the actual lumbar puncture needle itself threads through that. And it's really, really thin and flimsy, and they are more difficult to use. And then you've got the stylet inside the needle. So there's 3 components as opposed to 2 components. So it is better to use an atraumatic needle if you can, but if you're just not winning with them, I don't think it's unreasonable to use a sharp tip cutting needle, provided that you're using a 22 gauge needle. Don't use a 20 gauge. One other thing is to consider the length of the needle. So if you've got a bariatric patient, you commonly require a longer needle or even an extra long needle. So don't be caught out, be prepared. It's really frustrating when you're doing an LP, you've got it all set up, you're in the right spot, you're advancing nicely, you haven't hit resistance, and then you get into the hilt of the needle and you've just run out of needle because the patient is just too obese and you just haven't got into the thecal space yet, and you didn't bring a long needle with you. That's really frustrating. Usually you get these in the hospital setting by going down to radiology and getting a few from there. That's where I would normally get them from. Lastly, I would strongly recommend bringing multiple needles with you, like just bring a handful with you. If you only bring one needle with you, I personally just think that's hubris and you're just jinxing yourself for failure. If you bring a few for a backup, you only open the first one. Hopefully you are successful with your first needle and you're good, you're golden. But if you are cocky and arrogant and you just bring a single needle, you're just setting yourself up to failure, in my mind. Now, what else do you need? You need local anesthetic. So usually I use lignocaine 1% or 2%. I personally use without adrenaline just because I do worry a little bit about causing spinal artery vasospasm or something like this, although that's probably not actually really rational and it's not evidence-based, because you shouldn't be injecting your local anesthetic anywhere near the spinal arteries because you should be much more superficial than that. So it probably is okay actually to use adrenaline when you're doing a lumbar puncture with the lignocaine. And it may be reasonable to do so, particularly in a patient who has increased bleeding risk. So I've done lumbar punctures on patients who are a bit borderline in terms of platelet counts, and I have used adrenaline in that instance. It's important to remember the maximum doses that you can give of your lignocaine. So lignocaine without adrenaline, the maximum dose is 3 milligrams per kilogram. Whereas if it's with adrenaline, the maximum dose is 7 milligrams per kilogram. And the way I remember the difference is the dose is higher with adrenaline because the adrenaline causes local vasoconstriction, so the systemic absorption of the lignocaine is reduced, so you can give more of it, more than double actually, before you run into issues with systemic lignocaine toxicity. You also will require drawing up needles and syringes. I like to use 5 ml syringes as opposed to 10 ml syringes because they are a little bit easier to manipulate in your hands given the angles that you're working with. But that's just a personal preference, and I'd recommend bringing a few spares for both the drawing up needles and the syringes just in case you need the spares. You also need some form of cleaning solution, such as a chlorhexidine and alcohol solution, and that can either be in a bottle that you then pour into the dish, or sometimes you can get these pre-prepared lollipop type sterile swabs that you can then use to clean the skin with. You also need some form of marker pen, ideally a surgical marker pen. Some people do just mark out the spot by making an indent in the skin with the cap of a drawing up needle or such. I recommend against this, and we'll get to that shortly. Then, of course, you need your gloves and your gown. Ideally, you'd have a mask. We'll get to that shortly. And then in some instances, you may require an extra additional special CSF tube if you're testing for CJD in particular. So in Australia, that's a special type of CSF tube with a blue cap on it, and the walls of the tube are made of a different material so that they don't interact with the proteins which are being tested for in the CJD test. And there has been one or two occasions when the hospital hasn't had the tube, and I've done the LP anyway, and I've had to repeat a lumbar puncture on a CJD patient because we didn't have the right tube at the time and they rejected the specimen, and that was really quite frustrating. So don't fall into that mistake. Make sure you've got the right tube before you start if you're testing for CJD. Some other neurodegenerative disease biomarkers may also require that special tube, or they may not, so it's best to check with the lab beforehand. So, what options do you have in terms of your technique for performing the lumbar puncture? So, I would very, 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 very strongly recommend using your full proper sterile technique. I have seen some videos online, and I have seen and heard some historical stories from other colleagues of back in the day being in clinics like MS clinics where they do multiple back-to-back lumbar punctures, and they say, oh, we didn't use drapes, we didn't wear gowns, using a minimal touch technique. I really would not recommend that. It has an increased risk of infection. You should take the time to use a drape, prep the skin properly, wear a gown. Don't just do a dodgy minimal no touch technique. It should be a proper sterile procedure. In terms of the positioning of the patient, this is important. You've got two options here. So it can be in the lateral decubitus position, so the patient lying on their side, or it can be with the patient sitting upright. In terms of the lateral decubitus position, they should be in the left lateral position if you're right-handed, just so that when you're advancing the needle with your right hand, it's then angled towards the umbilicus, so angled rostrally towards the head. It just works better that way. And conversely, if you're left-handed, then I'd recommend putting the patient in the right lateral position. Conversely, if you're sitting the patient upright, I'd do it so that they're sitting over the end of the bed and then hunched over and cuddling a pillow or something like this with their legs dangling over the other end of the bed. So, which of the two options should you go for? Well, the lateral position is more difficult because you're navigating in essentially 3 planes of space, one additional coordinate that you have to battle against. However, there are some advantages to the lateral position. Firstly, you can measure an opening pressure. And secondly, it may be more comfortable or sustainable for some patients, so it may just be easier for the patient to lie on their side rather than awkwardly being hunched over and leaning forward over the end of a bed. Conversely, the sitting technique is easier to do for the proceduralist because even though technically you are still navigating in 3 planes of space, essentially it's kind of like you're navigating in 2 planes of space because the vertical sagittal plane of space should be very, very easy to identify. So that shouldn't be something that you're struggling against. So it is an easier procedure to do with the patient in the seated position. However, there are some disadvantages, so you cannot measure an opening pressure unless you then get in the thecal sac and then quickly roll the patient onto their side before you actually remove any CSF. And as I mentioned before, some patients, especially if they have joint problems or increased body habitus, they may find it difficult to sit in that position. Or if the patient is half unconscious or critically unwell, it might not be that feasible to get them in that position either. So which one should you choose? Ultimately, it's up to you. However, if you are doing a specific neurology training program, you are going to need to be measuring a lot of opening pressures. So I would recommend learning and getting used to doing lumbar punctures in the lateral position and then sticking with that. So when I learned the first time I did a lumbar puncture, I did it in the lateral position. I did that for a while. Then when I was a basic physician trainee, I'd missed a few, and so I actually went to the sitting position, and for about 2 or 3 years, I did my LPs predominantly in the seated position. But then when I started my neurology advanced training, I realized that, oh gosh, all my patients need opening pressures. I'm going to have to learn to do them in the lateral position again. So I switched back. And then for the last 4 or so years, I've just been doing them in the lateral position exclusively. So it's really up to you which of the two options you want to choose. But if you are able to do the lateral position and get good and comfortable and competent in the lateral position, then that would be my recommendation. Lastly, what position is the proceduralist going to be in? Well, you can do it standing, sitting, or kneeling. I personally like kneeling, and of course, your shoes and your lower legs and your knees aren't sterile anyway, and the top half of your body from your hips is still completely sterile, so it's still completely clean. And I just feel that I have a lot more control in that position. I'm nice up close to the bed, I'm right next to my sterile field, I'm right next to the patient. I don't need to worry about the chair being in an awkward position or getting wobbly legs. So I personally like kneeling, although I recognize that that's probably a bit unusual and most people don't do that. And it's also completely okay to do the procedure either sitting or standing. So, what are the actual steps to the procedure and what tips and tricks do I have at each stage? So, firstly, you need to do what we've talked about so far. So, you're checking your indications, checking that there are no contraindications. That includes checking the medications, the allergies, and the blood test results, consenting the patient, giving an anxiolytic prior if that's indicated, and letting the patient use the bathroom prior to the procedure. Then, what I like to do is when I'm collecting my equipment, before I've actually walked in the room to do the procedure, I like to just run through the steps of the procedure in my head to make sure that I've got all the right equipment. And it also helps just to prepare myself, get myself in the correct mindset for doing the procedure. And basically, it prevents you from getting halfway through the procedure and then realizing once you've already scrubbed in that you've forgot your lignocaine or something like this. That's very frustrating when that happens. Nextly, and perhaps this is just a bit obsessive compulsive of me, but I just like to have the room really nicely sorted out. So I don't like it when there's lots of clutter and patient bags and meal trays all around the bed and all around where I'm doing the procedure. And I don't like it when I'm crammed into a tight corner, pushed up against a wall without a lot of space to work with. So I like to get all of the crap out of the way and give myself a nice space to work. And I also don't like funny angles. So I just like to have the bed at a nice perpendicular 90-degree angle to the wall. Everything should be at right angles. It just helps get you in the correct mindset. And I do think that it helps with the actual procedure when you're angling the needle. It can throw you out if everything around you is at funny angles. Maybe that's just me, but I would recommend doing that. Next, it's all about position, position, position. So you need to have adequate exposure with the patient. You don't want their hospital gown or their shirt and their pants not pulled away enough so that you've got an insufficient working space. The last thing you want is for someone's shirt to start dangling into the sterile field that you've created. So make sure you've adequately exposed the area. Make sure that you've got good lighting. You don't want to start the procedure, scrub in, and then realize that when my head's in front of the patient, I'm blocking the light source and I can't see what I'm doing. You need to get the bed at the right height. So whether you're kneeling or sitting or standing, that will be a different height for you because you don't want to be scrubbed in, be about to do the procedure and then realize that your procedural hand is about 50 centimeters lower or higher than you want it to be. And then in terms of the patient positioning, if they're lying, then they need to be in the fetal position. So that means head crunched over, maybe cuddling an imaginary teddy bear and knees bent with knees up in towards the chest. And I really like to have the back parallel to the edge of the bed that you're working from. And it's nice to have the back about 30 centimeters or so from the edge of the bed. And I find that once you've got your drape on, that then just creates this really nice sterile field for you to work on where you can put objects if you need to. Next is all about marking, marking, marking. It helps so, so, so much if you have marked out where you're going and what your relevant anatomical landmarks are before you do the procedure, especially if you're doing it in the lateral position. So how do I do this? I've got my trusty surgical pen that I carry around with me in my pocket all the time. And I first palpate out the iliac crest, and that's the L4 level. And I actually mark that and draw an axial line across the height of the iliac crest. So I know that's where my L4 level is. And that's important because, as we know, the spinal cord ends in the adult at the L12 level, perhaps with a little inter-individual variation, but roughly at the L12 level. Next, I draw out the mid-sagittal line along the spinous processes. So I feel some spinous processes up in the thoracic region, and then just keep feeling the spinous processes all the way down until you get down to the sacrum, mark out where they are, and then just draw a nice, beautiful, long longitudinal line in the sagittal plane in the midline. So you should have this line here, the sagittal line, and this line here at 90 degrees to it, the line from the iliac crest. If they're not matching at 90 degrees, then you know that the patient's pelvis is tilted one way or the other. So really they should be at a nice 90 degree. And then what you do is you need to palpate out your intervertebral spaces. And I like to palpate a minimum of 2 adjacent spaces. And this is usually the L3-4 and the L4-5 space. So you find the cross that you've already drawn, you know that's the L4 level, and then you just feel for the first intervertebral space above that, and that's going to be L3, L4, and then you feel for the first intervertebral space below that, and that's L4, L5. If you want, or if they're not very nice spaces, you might want to go one lower to L5S1 sometimes, or in very, 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 very select circumstances, you might want to go one higher to L2, L3. I wouldn't routinely recommend that, but in rare circumstances, that may be reasonable. But in the most cases, it's going to be L3, L4, and L4, L5. And then I mark both of them. And again, I do that with big, nice diagonal lines. And I do them like this, and they're at 45 degrees to the other lines that you've drawn. So everything is just at nice, perfect angles. And then you should decide, before you even do the procedure, which of the 2 spaces is the bigger, better, nicer, juicier space. Which one are you going to go for first? So often the L3-4 space will be the nicest space, but sometimes the L4-5 space might be the nicest space. So you just need to choose which one you want to go for. Then, of course, you've set up your equipment, and then you want to scrub in, do a good proper hand wash, gown, gloves. I'm not going to go into that, but that's very important. And in terms of wearing a surgical mask, I did read one paper that found some evidence of CNS infections being caused iatrogenically by respiratory bloodborne pathogens after a lumbar puncture by a proceduralist not wearing a mask, albeit that's not a very high grade of evidence. And really, probably, if I'm being honest, one of the main reasons I wear a mask is it stops my glasses from slipping off my face. You might have noticed that I'm always recorrecting my glasses, and it's really annoying doing a lumbar puncture and your glasses keep slipping off your face, and wearing a mask does help to prevent that. But I think there's little to be lost by wearing a mask, and if it's going to stop the transmission of your own respiratory pathogens into the patient's central nervous system, then it's probably good to be wearing a surgical mask during your LP. Then you will need an assistant at this stage of the procedure just to help you draw up the local anesthetic and also to pour the sterile cleaning solution into the dish in the LP pack, because you can't do this once you're all dressed up and sterile, and you can't do it beforehand because you haven't fully unpacked the pack at that stage. Then you clean the area with your sterile solution. I'd recommend doing a circular technique, so starting in the middle and then moving outwards. And I'd also recommend doing it twice at least. So you want it to be really, really, really nice and clean. And sometimes patients might be like visibly dirty and have literal, visible, macroscopically apparent dirt and grit all over their back. You want to get rid of that. So if it takes more than 2 scrubs to get rid of all that, then fine, but you just want that back to be as clean as it has ever been before you start sticking a needle in there. But one trap to fall into is don't rub off all the beautiful marks that you've just done. I have made that mistake once or twice and I've regretted it, where I've done a really nice clean and then I realized that I rubbed my marks off. So it's a bit of a balance, and I do recommend when you're doing your marks, make sure you do really nice marks and use a proper surgical pen. Then you want to apply your drape. And I strongly, strongly, strongly recommend positioning the fenestration in the drape so that at least 2 of your adjacent CSF spaces that you've marked out are accessible within the fenestration of the drape. And again, that's partly for a hubris reason. I think if you have only given yourself one space to go for, if you miss it, then you're going to have a bad time because you don't have a second space to go for. Whereas if you've given yourself access to 2 spaces within the fenestration, then it doesn't matter if you miss the first space because you've got a second space to go for. And 99% of the time you get it with the first space and it wasn't necessary to have the second space, but it's the one time that you don't give yourself a second space that you then need the second space and you regret not having it. So just, it's very easy to have 2 adjacent spaces within the same fenestration. Then I'd use a generous dose of local anesthetic. Don't be stingy with your local anesthetic administration, and do it exactly in the spot that you're then going to insert the spinal needle after that. And make sure that you wait a sufficient amount of time after the local anesthetic before you then put the needle in. You can't just wait 10 seconds. You have to give it 2 or 3 minutes to actually take effect. Otherwise, there's not much benefit in using the local anesthetic in the first place, and it's quite cruel. In that 2 or 3 minutes, you can use that time to get the CSF tubes ready, check the manometer doesn't have any kinks or twists in it and things, so it's not wasted time. And when I'm injecting my local, I like to do a superficial bleb and then a bit deeper, and then without retracting the needle from the skin, I then reposition the needle in 4 different angles. So anterior, sorry, it's not anterior because the patient's in the lateral position. So superior, lateral, towards the patient's right side, inferior, and then lateral towards the patient's left side. And you're going to be injecting more superficially and also deeper. And towards the end, you can go quite deep with the local anesthetic needle just to check that you are indeed in the intervertebral space. You're not pushing up right against the spinous process or something like this. And make sure that you inject some of the local anesthetic deeper as well as just superficially. Finally, you're ready to begin with the actual spinal needle. So, how do you angle the bevel? So if the patient is in the lateral position, the bevel should be angled towards the ceiling. Conversely, if the patient is sitting in the upright hunched over position, then the bevel should be angled towards the side. It doesn't really matter what side. And the reason for that is in either case, the needle will be oriented so that it just slides between the longitudinally oriented fibers of the various spinal ligaments, as opposed to cutting and puncturing and pushing through the fibers. So it's less traumatic, basically. You angle the needle towards the level of the umbilicus. So that means slightly rostrally, slightly towards the head. And if you're doing it in the lateral position, this is really important. This is why it's nice to have that midline sagittal line marked out, is you need to angle the back of the needle so that it is parallel with the line that you've done. And it can be a little bit difficult to make that assessment when your head is right there. So it can help to lean back a little bit and just check, because you might realize that, oh, actually the back of the needle's a bit too low and it's aiming up towards the patient's top shoulder. That's not what I want. Or, oh, actually the back of the needle's a bit too high and it's leaning down towards the patient's lower shoulder. So you really want to lean your head back and make sure that the back of the needle is elevated to the right level so that it really is completely longitudinal. Sorry, so that it's completely parallel with the longitudinal mid-sagittal line that you've done. Then you advance the needle. After the first, say, 2 centimeters or couple of centimeters, once you've just gotten through the skin, you then need to start doing the technique where you retract the stylet every couple of millimeters to check if you're in the CSF space. Of course, exactly how far you go and how quickly and frequently you retract the stylet is going to be partly dependent on the patient's body habitus. So if they're morbidly obese, they've got a BMI of 40, you know that you're going to have to go in multiple centimeters before you're anywhere near the thecal sac, then you can probably be a bit more aggressive. Whereas if you've got a really thin, underweight elderly patient, then maybe you have to just go in 1 or 2 centimeters and then be much slower and more cautious with your stylet retractions at the beginning. It's hard to give specific numbers on this. I would say, as a rough rule of thumb, it's reasonable to insert the needle initially about 2 centimeters to get through the skin and the immediate soft tissue structures, and then to start the process of retracting the stylet and doing that every approximately 2 millimeters or so. I'm probably more cautious than most people, but it really is quite important to retract the stylet very frequently, just with very small additional movements of the needle. Now, what do you do if you hit resistance? So, if you hit up against a bone or some other anatomic structure, which isn't really the spot that you want to be in, and you clearly can't advance through that, and you know that you're in the wrong spot, what you should do then is just partially retract the needle. So, not the whole way out, just retract it partially, and just try re angling the needle. So, firstly, checking that you have it at the right height, and provided that is the case, then re-angling it either slightly more rostrally or slightly more caudally, and then re-advancing again. And sometimes I've been surprised. Sometimes I've angled it towards the umbilicus initially, and it has been perfect, and other times that hasn't been the perfect angle, and you just need to angle more rostrally or more caudally and then re-advance, and then you should be successful. Now, during the procedure, sometimes you do feel the classic resistance and then pop as the resistance suddenly dissipates when you've passed through the ligamentum flavin, and then you know that you're at or in the thecal sac and the subarachnoid space, and you know that you're in the right spot. So sometimes you do get that really satisfying push, 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 pop feeling, and that's great when it happens. But I will say that that is not always the case. It's not uncommon that you just don't get that pop feeling. So don't rely on it. So that's why it is important to always be retracting the stylet very frequently during the procedure. Now, what you do after you're in the spot and you've achieved CSF flow, so you've retracted the stylet and you can see that little bits of CSF are coming towards you and about to drip out the end of the needle. So this is where you measure the opening pressure. If the patient is in the lateral position, assuming that you need an opening pressure or might need an opening pressure, or if the patient was seated and you need an opening pressure, then that's where you need to quickly roll the patient into the lateral position. Now, there's two ways you can do this. You can use a three-way tap and then connect the manometer to the three-way cap. Conversely, you can just connect the manometer directly to the needle. I prefer to do this because I think it works just as well and it removes an unnecessary step. But it's just important to make sure that when you create a bit of an artificial 90-degree bend in the manometer, where the 0 is marked on the manometer, that needs to be where the bend is, and that needs to be level with the ground, and then it needs to go vertical towards the ceiling at that point. Otherwise, that reading will be inaccurate. The other important thing that many people forget to do at this point is the patient needs to extend both of their legs almost completely at the hips. And this is important to get an accurate pressure reading of the opening pressure. If the patient stays in the fetal position with both hips completely flexed, then you get a somewhat inaccurate pressure reading. The difference is typically about 2 to 3 centimeters of water, so it's not a major difference usually, but studies have shown that there is quite a bit of individual variability here. And the difference of a couple of centimeters of pressure can be significant in some instances. So imagine you're considering a patient who may have IIH, and if the pressure is measured at 22 centimeters of water, if you did or didn't have the hips extended, i.e., if it was done correctly or incorrectly, so if you're actually 3 centimeters of water off the mark in one direction or the other, that could be the difference between the patient technically having a normal CSF pressure or having a borderline or even an unequivocally high CSF pressure. So it can be important. So please extend both of the hips. Just ask the patient to do it slowly and carefully. Don't move their back around. Just slowly extend both your hips during the procedure at this stage of the procedure. If you're getting good CSF flow, you don't need to bother about rotating the needle. But if you're not getting good CSF flow, then it can help to rotate the needle through 90 degrees so that the bevel is then facing up against the patient's head, and sometimes that can improve the flow that you're getting. When you're measuring the pressure, make sure that the CSF column flow has truly stopped climbing before you call it there and say, yep, that's the pressure. And there's usually then a small up and down fluctuation as the patient breathes, or sometimes as they talk and laugh, but it shouldn't be consistently rising. It should have stopped that consistent rise before you say that that's the pressure. And then don't forget the pressure, because you can't actually write it down at this point. And I have almost forgotten a pressure before I was thankfully able to remember it, but that's something that you don't want to do. So really try and remember what the pressure is. Then you need to collect your CSF. So the trick I would say here is patience, patience, patience. So often in neurology, we need heaps of CSF. So we need 15 mils of CSF, maybe 20 mils of CSF for all the many neurological tests that we often like to send, or that we like to have the ability to add on if the need arises. So in Australia, at least, the CSF tubes are 10 milliliter tubes, and usually there's either 3 or 4 tubes in the pack. So what that means is you need to fill 3 or maybe 4 of the tubes about halfway up. Conversely, if you're in a different environment, like you're in the emergency department and you're just doing a lumbar puncture to exclude meningitis, then technically you really only need a few drops or a mil or so of CSF in order to do the infective test that you need. But the downside of that is you can't add anything on later if you need to, and you might not anticipate tests that are required in the future at the time. It might not even be possible to anticipate that based on the information that's available at the time. And it's not uncommon that we then need to repeat a lumbar puncture when the patient's admitted to get more CSF, and that's pretty frustrating. So if you are able to be patient and just get a nice quantity of CSF, that's so helpful for everyone involved. And the patient will thank you for it as well. As a rough rule of thumb, 20 drops is the equivalent of about 1 milliliter of fluid. So getting 15 to 20 mils is quite a lot of drops, and it can take some time. You don't want to waste all the precious CSF that you've got in your manometer. So what you can do is, once you've measured the pressure, you then get your first CSF tube, put it over the tip of the manometer, and then you kind of turn it upside down and disconnect the manometer. And then all the CSF that was in the manometer then falls with gravity into the CSF tube, and usually that's a couple of mils of CSF right there. One other strong benefit that I strongly suspect in terms of collecting a decent quantity of CSF is I think it really reduces the chance of getting a bloody tap. So if you collect a large sample, just imagine that the cell count is measured on the final tube, and if the final tube has got milliliters, say 10 through to 15, then think how diluted any bloody tap will be by that point. So you're much more likely to get a nice clean CSF with few red cells in it, or no red cells in it, ideally. Conversely, if you have a bit of a bloody tap and you only collect 1 mil of CSF in one tube, or maybe half a mil in 2 tubes, then that CSF is likely still to be bloody, and you might get a really high red cell count in your sample. And that can be a problem, actually. There are correction factors in terms of how many white cells are acceptable per couple of hundred red cells or a couple of thousand red cells in the CSF, but they're not perfect. And if you've got a really bloody tap, it can make the CSF pretty difficult or not even possible to interpret for some more advanced testing, like some biomarker testing or some other forms of testing. So if you collect a good quantity of CSF, then you're very likely to get fewer red cells when the cell count is actually measured in the final tube that the pathologist tests. Now, it's also important to take note of the color of the CSF when it comes out. Is it clear and colorless? Is it yellow, turbid? Is it bloody? Is that blood clearing with time? Was it just a bloody tap or not? I can say that I've only done one lumbar puncture where the CSF came out yellow. It was full on yellow. And then when I looked at it in the CSF tubes after I collected them, I could see these little wispy white fluffs in the fluid. And it looked like there were egg whites that had been dissolved in the fluid. I actually took some photos of it because it was just so incredible. And the patient's protein came back as being off the charts. I think it was 12 or 13 or something like this. And unfortunately, that patient turned out to have a really, really nasty CNS lymphoma from memory. One other tip that you won't read anywhere, but it's a super important one, is when you're setting up all your equipment, you need to think about how the lids of the CSF tubes are going to be positioned so that when you pick them up during the procedure, you can actually screw them onto the tubes. So put the lids so that they're face down on the table so that when you're holding the CSF tube in your left hand and using your right hand to grab the tube, you pick it up and then you can just twist it onto the CSF tube immediately. Otherwise, the tube's going to be upside down, but you don't have a spare second hand to get it the right way up, and it's really frustrating. I'd also strongly recommend screwing each tube's lid on at the time rather than collecting all 3 or 4 tubes and then screwing the taps on, because that's just asking for trouble in case someone knocks the trolley and you spill all your CSF or something like this, or just the weight of the tubes and the CSF knocks over the kidney dish and all the CSF falls out. That would be a sad day. Then once you've collected all your CSF, you need to then remove your needle. Lots of texts and people recommend replacing the stylet before you remove the needle to reduce the risk of a post-LP headache. I personally don't like to do that just because I don't like the idea of putting a stylet that's just been sitting on a surgical field for however long back into the CSF space before removing the needle. I just don't like the idea of that. From an infection perspective, it's probably not evidence-based, but in any case, I just removed the needle without the stylet. And the needle should be removed with the bevel in the same position that it was in when you inserted it. So for instance, in the lateral decubitus position, the bevel should be oriented towards the ceiling before you remove it, for the same reason as the positioning when you inserted it in the first place. You then dress the puncture site and you need to measure and remember the finger prick BSL. And if you need any paired serum tests for any of the CSF tests that you're ordering, then now's the time to collect them as well. It's very routine for patients to be told to lie flat for 4 hours routinely after the procedure. However, that's actually not evidence-based, and I'd recommend against that. You don't need to do that. However, if the patient does then develop symptoms of a post-lumbar puncture headache, then they do need to lie flat because that forms part of the conservative management for a post-lumbar puncture headache. Now, this is the last slide, and the slide is, what tests do I actually order on my CSF? And this comes up all the time. So I've tried to come up with an exhaustive list. Again, it's probably not truly exhaustive. I'm sure that some of you can think of a rare, obscure test that isn't on this list, but this is a close to exhaustive list, and I can't think of a time that I've done a lumbar puncture in the last 8 or 9 years when I've needed to order a test that was not on this list. So, firstly, there are the always order tests. So you're always going to order a cell count, culture, protein, and glucose. So you're just basically always going to order those 4 tests. So I'll say it again: cell count, culture, protein, glucose. The only exception would be if you're just not going to send any tests at all. So maybe if the patient had confirmed IIH and they were pregnant and they were just coming in for some serial therapeutic LPs until they deliver their baby, and that's the only reason that you're doing the LP, then you could argue that you just don't send anything. Even then, I probably would still send a basic cell count, culture, protein, and glucose just to make sure that no other significant change has happened to explain some of the symptoms that the patient has. But I'll leave that up to you. But in almost every circumstance, you're going to order those 4 tests. Then, depending on the clinical circumstance, there are additional groups of tests that you may need. And I've grouped the tests according to the type of clinical circumstance. So, and this is how I remember them, and it's hopefully a way that you can remember them as well. So firstly, I think of my infective type tests. So that's an infective multiplex PCR. In Australia, the proprietary name of the test is called a biofire assay. I order a cryptococcal antigen often, and you may also need to order other specific infective testing if it's clinically indicated. So tuberculosis testing, maybe extended fungal testing, syphilis, HIV, HTLV testing. Then think about hemorrhage. So am I thinking about a subarachnoid hemorrhage? If so, you need xanthochromia. And it's important that you have brought some foil with you, some aluminium foil, if that's the case, because you need to wrap the specimen in that aluminium foil ASAP before it's even sent to the laboratory so that the ambient light in the environment doesn't start breaking down the red cells. Next is I think of some of my inflammatory type tests, especially MS and sarcoid type related tests. And I do bundle in a few less specific tests in this group as well. So an IgG and an albumin level, so that you can calculate an IgG to albumin index, oligoclonal bands, of course. Sometimes an ACE level, although we do know that ACE is not a very helpful test either in serum or in CSF, so lots of people would choose not to order an ACE, but I've put it here in case that's something that you do want to order. I've also put in some very much non-specific tests which can be positive in inflammatory conditions or other conditions as well. So an LDH, a lactate dehydrogenase, and also in some centers a neopterin level. So neopterin is in vogue in some centers in Australia. I imagine it probably is elsewhere in the world as well, but it's not a specific test, but that's something to consider. The next group of tests are your malignant type tests, and really that consists of cytology and flow cytometry. And it's really important to know that you cannot add on cytology after the fact, and you probably shouldn't add on flow cytometry either. You can, but it's not optimal. But especially for cytology, it can't be added on after the fact because the cells break down and they become uninterpretable. So it's really, really important that if you need CSF cytology, you realize that and order it at the time rather than thinking a day later, let's add on some cytology, because you won't be able to do that. The next group or bundle of tests that I think about are your autoimmune and paraneoplastic encephalitis type tests. So that's your anti-neuronal antibodies and your limbic encephalitis antibodies. And specifically, I think of NMDA, LGI1, Caspar2, GAD, GABA, AMPA, DPPX, Eglon5, and then I usually write on the request and the rest of the full panel that you have, because I stop remembering the names of the antibodies at that point, and there's always new ones being added on, and the laboratory will almost always run the antibodies as a panel, but it's just so that they get the idea that you really do want the full panel of antibody tests, assuming that is what you want clinically. Now, I usually don't order these, but sometimes if you're considering NMO spectrum disorders, or if you're considering MOGAD, then you can order the antibodies for them as well. So aquaporin 4 or NMO antibodies or MOG antibodies. But the reason that you don't usually order these is actually serum testing is almost always completely adequate, and CSF testing is very, very rarely required for these conditions. But in some rare select circumstances, you might consider ordering them in the CSF as well. Then I've got my inflammatory neuropathy type test. So basically that's your anti-ganglioside antibodies, so GM1, GD3, and GQ1B. So sometimes they may be indicated depending on the clinical circumstance. And then lastly, I've got my cognitive and neurodegenerative type tests. So if you're thinking about CJD, then that's going to be your 1433 protein, but also your RT-QuIC, QUIC assay, which is more sensitive and specific. But ironically, it's not quick. It can take weeks and weeks to come back. And usually also a total tau. So they're the three tests that in Australia we run for a CJD screen: a 1433, an RT-QuIC assay, and a total tau. And then if you're doing, say, some Alzheimer's testing, then you're going to be testing your amyloid, and you'll also be testing phospho-tau, so phosphorylated tau, in addition to total tau, to get your ratios. And there may be some other neurodegenerative biomarkers that you may order on a case-by-case basis if clinically indicated. Now, don't forget your paired serum tests for some of these conditions. So if you didn't get a finger prick glucose, then you should get a serum glucose. And then if you're ordering CSF oligoclonal bands, then you need them in the serum as well. And they're the same thing essentially as an EPG, an electrophoresis, a protein electrophoresis. And then if you're testing for TB or syphilis or HIV or HTLV in the CSF, then that should be done in the serum as well. Same with ACE. And the same is true for all of the autoantibodies as well. And some autoantibodies are actually more sensitive in the serum than in the CSF. And conversely, some antibodies are more sensitive in the CSF compared with in the serum. So that was it for today. Thank you so much for tuning in. Please like, comment, and subscribe if you found this video or this podcast helpful. Visit our website, rneurologyeducation.org. That's R with the letter R for all of our media formats and additional content. Find our video presentations on YouTube and our audio podcasts wherever you listen to your podcasts, and join us on your preferred social media platforms at the same domain, R Neurology Education, or email us at contact@rneurologyeducation.org with any questions or to subscribe for updates when new content is released. From cortex to curiosity, this has been Risfeld Neurology Education. Until next time, keep calm and synapse on.